let's get it on recording and let's get going for the day. So this week we are doing chapters 43 and 44, Hematology, Immunology, and the child with cancer. You have due this week a quiz number 4, which is exactly off the lecture today, okay? Case studies, congenital heart, cystic fibrosis are available and due by Sunday. And this is the week for the NCLEX. So if you've already done them, you're already good. So that's what's due. I am doing a exam review on Thursday. There's another one Friday, Saturday. And if you look at your calendars, it's the Zoom link and everything there. So it's easy for you to find out when and where it's being done. So I highly suggest at least go to one live one and listen to a minimum of one of the other ones. It does give you a different way of descriptions of things, and sometimes it helps you remember. And that's the best way to do those things. I've been asked how to study. I think that the PowerPoints that we give you for the study review has the information you need. And remember, these PowerPoints, these study PowerPoints are also good for your HESI. So if you're studying for the HESI, to study the 3 study reviews are excellent to use. And also before your NCLEX. So these study PowerPoints are awesome. Also to review your Kahoots and then refer to your book for anything you're not understanding. So that's how I would be studying for this. Remember, it is week 7. This is week 6, and we are halfway through the program this quarter. It's amazing, it goes quick. Now it's hold on, because it gets a little bit rough and busy. There's a lot of stuff due for community and for pediatrics. So just try to keep ahead of yourself. I am already accepting some of the clinical pediatric assessment projects already. And I am sending back, change this, do this. You need to do this to try to get you with your 100, your best grade you can. And as long as you keep turning it back, because it's multiple times you can turn it in. I don't have it on a number times of how many you can turn it in. So if I tell you to do something different, do it, because my goal is I want you to get the best grade you possibly can on the subjective grades. Now, if you've noticed, I've turned on the homework grades. They'll be on for 2 weeks. Okay, it's just showing you how it can help or hurt you. So this is your homework grades that they're on right now, to let you know. It's something we do for those students who don't like to do homework. And it sort of shows them that you can fail from not doing homework. Last semester, we had several students who passed the course but failed for no homework. So don't let yourself be one of those things. And you know the online group is pretty strict. If you get it in on time, you get full credit, whatever your grade is. If you're 1 week late, we take 10% off. After 1 week, we do not accept any homework unless there is an extenuating circumstance that we know first. Maybe you had COVID and then your family got COVID, or there was, something happened in the family that you needed time for. Those things, extenuating. But this is something I know before things are due, okay? So, but I want to thank you, because most of you are right on time. I don't have hardly any late work, so I appreciate that. So thank you. So any questions so far? Remember, I will record every recording, and you will have the other professors recording too, which will be on your announcement pages, so you have it. And every time I post it, I always post the study PowerPoint with it, just to make sure you don't have to look here and look there. I try to keep you as organized as I can. So let's start with our PowerPoint for today. So chapter 43, hematology and immunological dysfunctions. So when we say hematology, immune, we're immediately going to think we need to look at blood to determine what does our hematologic dysfunction or function looks like. We're looking at things like the white count, which can show how good your body is taking care of some infections. We can look at hematologic anemias. We can look at CBCs. We can look at the red cells, the hemoglobin, hematocrit, platelets, and all of these things can tell us something and can guide us to a diagnosis. Also, as we're doing problems with these dysfunctions, a history and physical. Many times children come into the doctor's office or emergency room, they're complaining of bleeding too much or bruising or pain in something or just lack of energy, fatigue. And this can direct us to doing a CBC and probably finding low hemoglobin hematocrits. As a child gets older, we are not giving them all those iron fortified foods like formulas or your food, your cereals that we give initially, all iron fortified. And now we have these children after the age of 1 on whole milk. So the iron isn't getting in there as much as we can. And not every child likes green leafy vegetables and liver and all those things that have iron in it. So we know there's poor sources and that can lead to anemia. If a child is constantly getting sick or bleeding nosebleeds or rectal bleeding or just cuts with bleeding, something's happening and we need to look. So red blood cell disorders, the first thing is lack of them or decreased, and that's known as anemia. The red blood cells carries around oxygen, and oxygen is the nutrient to give you energy. If you don't have enough oxygen, you're tired, your body's going to tire out really easy. So if we're seeing a child getting tired, we can sort of think it's probably some sort of anemia that's going on. We know that there's many different causes for them, and we know it as different shapes of cells. There's sickle cells and there's actually rectangular shaped cells in one of the diagnoses. So when we're seeing red blood cells and hemoglobins, the levels are low, we know to start looking a little bit harder at what is the cause for it. A child having a hemoglobin of 10 or 11 is actually good because we know they're not having enough iron as they should. So there's different ways that we don't have red blood cells, whether they're a decreased production or you're losing them quick, or these red blood cells are being destroyed quicker. So those are the 3 ways. So the one thing that we see in all anemias, you are going to see the body saying, all right, heart, I'm going to be a little faster. Maybe I can get those blood cells around and maybe the oxygen will get there. Well, it's not going to work because you don't have blood cells, so you're not carrying oxygen, but you're going to have this heart beating hard. You're going to see that fatigue, that shortness of breath. And the one thing that we can hear is this really swooshing murmur in there. It's because the cells are far apart, they bang off of each other, and then we hear that sort of systolic murmur or that swooshing in there. Nutritionally, what causes anemia? Well, iron deficient anemia, B12, intrinsic factor, it's one of those things. Also, we have something called a bone marrow failure. So decreased red blood cell production, the bone marrow's not forming the cells like they should. And the biggest one is aplastic anemia, and then there's the cancer ALL. Now, aplastic anemia is A, which means without. That means red blood cells. That means white blood cells. That means your platelets. You're not having enough. The cells are not being produced the way it should. In ALL, or a neuroblastoma, which is another cancer, it's also, you're not getting the cells you need. In ALL, you'll see decreased white cells. You will see decreased hemoglobin and hematocrit. And we'll go into that a little bit more. Increased red blood cell loss, this is when you're losing things quick. I mean, think of just acute blood loss as in, you're bleeding. One of the biggest way children you'll see bleeding is when they have these nosebleeds, epistaxis. In fact, epistaxis can clue in the healthcare provider that something's not right. And then they'll go looking for things like hemophilia or ITP or other types things, but hemophilia and ITP are usually diagnosed because of nosebleeds. So even though they're bloody and they're really are scary to a child, it's actually giving that clue, that hint. And then we have something called an increased red blood cell destruction, which means in the body, these cells are being burst. And this can cause a lot of things. It can cause dark urine, again, tachycardia, but it can show that really yellowish looking sclera going on, and the big liver and spleen, you'll see that. Now, one of the things that causes this increased red blood cell destruction is sickle cell anemia, one of the most common ones that we all know about. And we know that the cells are born, they're like little sickles, but they don't last long. So these sickles don't carry around oxygen, and they're bursting quickly. Another thing that can happen is something called thalassemia. And thalassemia is these rectangular shaped cells that tend to burst. The biggest thing with thalassemia is the amount of destruction that occurs causes all of those cells to disperse their insides out into the bloodstream. And one of the things that's in the cell is iron. So it causes really high iron levels. So this child, which becomes adults, is going to need that iron removed, maybe an iron chelation therapy or something called an apheresis, which can take certain substances out of the body, similar to dialysis, but just not quite. And then, of course, chemo and radiation infections all causes the destruction of red blood cells. So what do you see with anemia? Well, as I said, your cells aren't tightly packed. They're spread apart, so it's a hemodiluted thing. We know that it produces a murmur because of the swishing that goes through. There's decreased blood oxygen carrying components of the blood, so you'll see cyanosis, you'll see that bluing. And we know that the oxygen helps the body grow. So if we don't have proper oxygen, you're going to see growth retardation. So how do we treat anemia? Well, number one, we have to determine that you have it. So the history, physical, and just simple old CBC, complete blood count. Now, we're not just going to treat anemia. We can't just assume that it's an iron deficient. We need to find out, what is it? Is it nutritionally? Is it something to do with blood loss? What's happening? So first find out why, and then we're going to treat it. Now, if the hemoglobin hematocrit are really low, a transfusion will be given. Or if it's nutritional and it's not too low, we can just change the diet, or maybe add iron if it's iron deficient anemia into the program for this child. Sometimes the child comes in and is just so dehydrated and anemic, they're going to give IV fluids. Just be careful. If you're starting out with a low hemoglobin hematocrit, with low blood volume, you give volume back to that child, that hemoglobin hematocrit will drop even lower, because now you've diluted the blood even more. So how are we going to take care of anemia? Well, they don't have oxygen. They're weak, they're tired. We need them to rest, okay? Giving them some oxygen can help make sure that every cell possible is going to carry some oxygen around. Does it work or not? It's controversial, but it's better to give it than not. Part of the assessment is looking at how old is the child and what is their race. We know that sickle cell anemia is the African American. We know that thalassemia is the Mediterranean background. So those are two things to look at. Checking the history, and then just to rule out active GI bleed, we're going to do a stool for occult blood. Whenever we're going to do any sort of laboratory tests involving needles or anything with children, get them prepared, get on their level, let them touch the stuff, let them know what's happening. Now, if we're going to have to draw blood on a child with anemia and that kid is screaming and yelling, they are already deficient of oxygen. They already tired easy. Now you've really compromised them a lot. So getting them prepared is the best thing. And our goal is always to prevent complications. So iron deficient anemia, we know, is not enough iron in the body. Usually it's because they're not eating the proper things. As I said, it's always iron fortified cereals and formulas for infants, in the prematures also, and maybe adding a vitamin with it too can help. Adolescents are also at risk for iron deficient anemia. We know that body image is so important, so they're not eating the way that they should. And then they're on the go and running all the time that they're not eating good. And there is that big growth spurt that occurs. So at that time, you will see these adolescents with iron deficient anemia. Sometimes when we switch from the formulas to whole milk at 1 year old, that's the milk baby. They're not getting the iron they need also. So what do? What is our treatment? Iron deficient anemia? Well, let's replace that iron through diet and maybe through iron supplementation. Dextram, those IM Z-Track injections might be, or just simple oral medications. Remember, iron, if we're going to give that liquid stuff, if the kid is older, sip it through a straw because it can stain the teeth. Sickle cell anemia is those sickle-shaped cells. It is the African American, have a lot. If two parents have just the trait, every child has a 25% chance of having the disease. So sickle cell, it is when the body takes the bifurcation or when the vein splits and it sort of gets caught in there and then all the cells back up behind it. So below it, this body is not getting the oxygen and the nutrients from the blood. It's not getting it. So that's going to be hypoxic and it could lead to death and even tissue problems, okay? Which could cause death of tissue. Above it, it's going to be swelling and painful and hurt due to all of this extra fluid in there. It's just stretching and stretching. So what's the problem with this? The vessels are so little, the sickle cells can't go through. So how do we treat this? What do we do with this? Well, when we're going to have a sickle cell crisis, it's usually due to some sort of dehydration. Could be infection. We know fever, you lose fluid. That's why we should increase fluids when you have a fever. Or if you're out playing sports and you're not rehydrating, that can cause it. And we always know stress always plays a factor in sickle cell anemia. So our goal is to prevent that sickling at all courses, keeping those hydration going on. But let's say we're going to go into a crisis. We got an infection and now we are slightly dehydrated and now I'm having a sickle crisis. Number one, nursing priority is to initiate fluids. And why fluids first? It dilates the vessels, allows the little sickle cells to go through and relieves that backup, okay? We also, of course, you're going to give pain medicine because it hurts. But the first thing is fluid because it helps to relieve the pain, and then heat because heat dilates those vessels very more. So if it's the knee that's causing the problems, we're going to put heat on it. We're going to give fluid to that child. And then, of course, those pain medicines, you let that child rest comfortably. And then when we're giving all of these things, most likely it's an infection that's caused it, and we will be giving antibiotics. Now, one thing I have noticed with all sickle cell crisis children, when they come into the emergency room, their hemoglobins and hematocrits are very low because we know that these cells don't last long. So the hemoglobin hematocrit could be 5 and 15. I've seen that low. So a lot of the treatment here also could be blood transfusions to help get those hemoglobins hematocrit up. So let them rest, give them a little bit of oxygen, hydrate, hydrate's your big thing. Electrolytes, seeing how those are doing, pain medicine, antibiotics, and blood, that's your treatment. So for the pain, number one, hydration, get that vessel open, pain medicines, and heat. Prognosis is there's no cure. We know that the big things is with these children is they are immunocompromised, they're immunosuppressed. So it's infection is the big thing that can cause death in children. If treated and caught quickly and gotten the treatment as quick as we can, usually these children become adults and they can live a pretty decent life. So what are we going to educate our family about? Well, it's early intervention. If we're seeing that they're low-grade fever. Now, these children and parents are said with a fever of 100.5 or greater, notify the healthcare provider or go to the emergency room so you can get those antibiotics quickly so that you're not letting the infection go too far. So fever, infection is big number one. Now, we give as a prophylactic to these children a penicillin once a day. So they'll be getting it from the ages like 2 months to 5 years. And this is prophylactic to try to help that immunosuppression to keep them from getting infections. Now, the one thing that I, as a nurse, just working with sickle cell in the emergency room, didn't realize at first is that sickle cells can occur in the head. And we need to look out for those neurological signs, the pupils unequal or headaches, and we need to suspect that it could be a stroke. Also, respiratory wise, they can look like they're having pulmonary embolus, that pain in the chest. And those are your most dangerous sickling crises that you might have. So to be prepared that if they're having a headache, take it seriously because it could be a stroke that's occurring. Because you've blocked off the blood, it's building up, you can see what can happen. Children who have sickle cell need to be treated normally, and they need to be given the tools and the education to understand how to prevent sickling, keeping hydrated and keeping away from infection, washing their hands. So, medical emergency, well, first they're going to rest. IV therapy, bolus fluids, get those veins open. We're going to give them electrolytes, analgesia for pain, and we tend to forget sickle cell hurts and give a dose when they come in, and when it's due, we forget to give the next one. Remember, if we don't treat it until it's too bad, nothing's going to help at that point. We don't want to do that to these children. Again, blood replacement and antibiotics. As I said, it is prophylactic antibiotics from 2 months to about 5 years old. And we're going to be given blood transfusions because it's giving oxygen back to that child so that the body can relax, the heart can slow down so that there is a little bit of extra oxygen with that blood transfusion. And we do monitor the reticulocyte count because it looks how the bone marrow is functioning. How are the cells being formed? Thalassemia is the other blood loss that we see, and it is a shortened life of the red blood cells for descendants of people living by the Mediterranean Sea. And these are your rectangle ones. And these are quick to explode into the vessels. And this is the one you worry about, iron, because the iron in the cells explode into the vessels. Now, there's 4 types of thalassemia. You don't really have to know all the different names and what they're called, but Thalassemia Major is Cooley's anemia. And this one, you need blood transfusions regularly to survive. There's no way to do anything but give them transfusions. And these transfusions just gives them new cells. And then of course they die. So then they need more. How often, how regularly depends on the patient. Could be twice a week, once a week. It all depends on the patient. So how do we diagnose thalassemia? Well, it's not there at birth. It's something that tends to show up later on. By 6 weeks old is when they start having red blood cell changes. And the thing with children and infants, we know up till about 6 months old, they're not making their own cells yet. So their hemoglobin hematocrit will come down normally. And as I said before, they could go down to 9 and 10 by 6 months old. So are we looking yet for thalassemia? Not quite yet. So it's really hard to figure out in the younger ages. The hemoglobin hematocrits will come
Ms.
down.
Boger,
Yes.
I'm so sorry. You were saying 6 months. Are you meaning 6 weeks?
6 weeks, yes. No,
Okay.
you can see hemoglobin hematocrits at 9 and 10 at 6 months old. That's normal because the body doesn't produce cells yet.
Okay.
They change the shapes of them by 6 weeks. And unless you look for a smear, you don't see those changes. And it's not common to look at for a smear. Okay. Okay. No problem. Remember, if we don't have oxygen, we're going to see growth failure because oxygen is your nutrients of the body. So again, how do we take care of these children? It is blood transfusions. Now, because of the amount of iron that is released from these cells, there's some sort of iron chelation therapy, whether it is this dextramine, destrafol, which basically binds with the iron and you get rid of it through the kidney, or it could be through an apheresis where they can remove components of it. So this is a disease that you're chained to blood transfusions for your life. They can live into adulthood with it as long as they're diligent with treatment and getting their blood transfusions. Because remember, no blood transfusions, blood cells burst, iron is in the body, which can be very toxic. And then the anemia can cause the heart to beat too fast. So then they go into heart failure disease. They do sometimes go ahead and do a splenectomy, and the spleen stops producing these cells, these ones that burst with the iron. And then you're just having the blood transfusions with those cells. And of course, multi-organ failure can occur due to all this anemia and the iron that's going on. And maybe the bone marrow transplant is a cure. So compliance with transfusions and chelation therapy and keeping this child calm. And this kid will always be in and out of the doctor, always be feeling weak. And it's a lot on the child and a lot on the family. It is a constant concern of getting blood transfusions and monitoring for problems, even with infections, because of what's going on with these children. So this is a really sick kid. They can grow up, but again, they have to know where the next transfusion is coming from. Now, aplastic anemia means A without, right? Atresia means no valve in the heart. Aplastic anemia means without. And what happens in pancocytopenia is that all things, the red blood cells, the white blood cells, and the platelets all are depressed. So this is every blood component is depressed. The hypoplastic is only the RBCs, but again, remember, you need RBCs to carry oxygen around. So how do we treat aplastic anemia? Well, aplastic anemia is basically immunosuppressive therapy, which means telling your body to leave the blood components alone. And it's really similar to leukemia. They give chemo and whatnot to this child for the body not to continually breaking down blood components, and then bone marrow transplant again for this one. Now we're going to go into defects in hemostasis, or basically bleeding, and platelets. What do they do for the body? So when you think of a body bleeding, you think of hemophilia. Hemophilia is when there's a component of the clotting system of the body that doesn't work. So the body doesn't stop bleeding. So you get a cut and you bleed and you bleed. And then if you bruise, you bruise, you bruise. It doesn't stop. This is given to the child by the mother. 80% is inheritable, X-linked recessive. So mom, give this to the baby. And the treatment involves what blood clotting factor is missing. Now, there's 3 types of hemophilia. I mean, we all hear of factor 8. That's the common one. That's what everybody knows about. But there's also the Christmas disease, and that means factor 9 is missing. Factor 8 is there, but 9 is missing. And it works the same way. They bleed. The other one is called von Willebrand. And this is one of the scientists who found this clotting factor and gave his name to it. But it's not only von Willebrand factor of blood clotting, it's also factor 8. How do we treat hemophilia? Well, if we bleed and we see this thing going on, we need to give a factor back to the child. So when we see a child, now we don't always know at birth. Sometimes we find out later on these children. And as I said, sometimes it's just of these bleeding, could be nosebleeds. It could be bleeding into joints. Hemoarthrosis or bleeding into the joints really destroys the joint sacs. And this can cause a child, if not taken care of quickly, destroy the joint, and child ends up in a wheelchair. So we need to make sure these children know you fall down on your knee and it's bleeding in there, you need to stop and do the proper thing for it. We'll go into that. And then, of course, bruising, ecchymotic areas that you don't know why. So I said it comes from mom, X-linked. And what do you see with hemophilia? Well, whatever factor it is, you'll see low levels, 8 or 9 are von Willebrands, but you'll see a prolonged PTT level. And the PTT is what we use to measure heparin, right? Same thing for hemophilia. So you'll see a low factor and a prolonged PTT, but platelets are normal on this child. You can also have bleeding problems from low platelets. This one is normal. And these other ones are another type of things that we monitor for bleeding, the parathyrohormone and the fibrinogen level. So how do we treat it? Most of these children do home treatment. They have factor 8, factor 9, they mix it up and they give it IV at home. I was telling the other class, there was a story about this 9-year-old kid. It was my kid, came into the emergency room, literally had fallen down on his knee and it was swollen. It was on the weekend. They didn't know if they should be given the factor. So they came in and the ER doctor said yes. And the father said, do you mind if I give it to my son? I have it here. I said, no, don't mind. He mixed it up. He and the son figured out where they wanted to put it in the arm. They said, all right, right there, Dad. He put it in and administered it. He did it better than most nurses. And the kid was happy and the father was happy. And I commended him. I said, you did amazing. And he goes, thank you so much. He said, I've been doing this for a while and I don't want to hurt my son. I said, well, how you involved him to pick out the site, that was amazing. And the thing is, I had a orientee with me who got to see a father do it. I said, see, that's how you start an IV and give something. So they do it at home and they do a really good job with it. Remember, hemophiliac starting an IV could create more bleeding, right? He did a phenomenal job. Now, sometimes it's mild and you could do nasal spray, this desmopressin. Ever hear of DDA VP before? It's given for what? Diabetes insipidus, right? But it's the same thing, but we can use it for hemophilia. And then sometimes we give this aminocaproic acid, but mostly it's the clots factors that we do give at home. So prognosis, if they are mild to moderate, normal lives pretty much, but really watching out, for the bleeding episodes. And if they are really minimizing the amount of joint damage, when they are bleeding in the joint, they're not going to end up in a wheelchair. They'll be doing well. So it's being aggressive in their care. There is a gene going on. They're working on it. It's sort of there, but not quite approved yet. And it would be really great if we could find it. So prevent bleeding is our goal. Keep the environment safe. Remember, soft toothbrushes, right? We don't want to have them bleeding in the gums. And if we have an episode where we've fallen, the knee hurts, what do? I have this thing below, says price. Well, number one, you protect the child. But let's say they fall and they hurt. You need to rest it. You need to ice it. You need to put an ACE bandage, compress it, and elevate it. You put ice to constrict the area. You compress it to stop the bleeding. It's like putting a finger on, something that's bleeding. And you elevate it because you don't want the blood dropping down there. So it can really help with those devastating results from joint damage, et cetera, on it. Again, families at home that are doing this need to be supported. And just like I told the father what a phenomenal job he was doing, he felt pretty good when he left the ER that day that, I had watched and said, you did amazing. And of course, genetic counseling is needed. Immune thrombocytopenia, immune thrombocytopenia purpura is the whole name, and it's otherwise known as ITP. When you see ITP or purpura, P, think of platelets. Platelets can help or can stop bleeding at a normal level. With ITP, those levels are very low. Low platelet count causes bleeding. So how would you see these kids present? You're not going to see them at birth. It doesn't happen that way. It's later on, and usually it is something that comes and it will go away. It's not going to be chronic. It's just going to be an acute stage of it. And usually there have been sick. Some sort of upper respiratory infections occurred. And these children come in, usually, again, nosebleed, or the parents are seeing this little rash, this purpura, petechial type rash on the legs, the arm, the trunk, but he hasn't fallen down. I don't know what's going on. What's this rash from? So when we see these things, we'll say, okay, he's just been sick a little while ago. Okay, oh, he's got this rash. What are we going to do? Well, we need to look at platelets. So we're going to do a CBC. We're going to look at the platelet count. Now, if it lasts over 12 months, we can't get rid of it with the treatment. That will become the chronic one that will maintain with it. But most of the time, it just is acute stage. We cure it, it's gone. So how do we take care of it? Well, we're going to give IV, IG, or IV immunoglobulins and anti-D bodies. And these are the ones that help. And then you'll see in the bottom, sometimes corticosteroids are given. And this is the treatment of ITP. Now, sickle cell, we needed to start an IV and give fluids. This has nothing to do with the vessels being obstructed. It just means that they're bleeding into their skin, has nothing to do with volume of fluids. This is something that will give the corticosteroids, the IVIG, an antibody, and it will take care of itself. So if we're a nurse and we know our child is ITP, you will not do anything to stick this kid. So no IM injections. You're going to give them a soft toothbrush. You're going to watch for bleeding. Any child with a low platelet count, you're going to have them on bleeding precautions because they will bleed. And we will be watching the child if they're bleeding anywhere, and we're going to be monitoring those blood counts. And again, giving corticosteroids is needed. Now, DIC, I mentioned, it's just a really complex thing that occurs, and it's usually due to overwhelming sepsis in the body, and it has to do with the bleeding coagulopathies. Literally, the body turns almost like it has heparin, thin blood everywhere, and it requires all sorts of blood products and heparin to help these children. And it takes a long time to turn these kids around. So as I said, finding out what was going on, giving them transfusion, blood products, and heparin. And, I don't go too in depth with it because it's something that even nurses working with DIC have to really sit back and think about. It's pretty complex. Nosebleeds, I've mentioned them because if you have a bleeding coagulopathy, probably this is what you're going to see. Usually the case history will go like, all right, the kid went to the doctor, or no, kid last week had a nosebleed, he held it, it went away. Well, he just had 2 more this week, so it came to the doctor to find out, why is the kid always having nosebleeds? They said, okay, put a little bit of Vaseline on the nose, maybe it's due to this little upper respiratory you have, and they continue nosebleeds. They'll say, all right, let's check a CBC, because remember, platelets and blood counts. Let's see what's going on there. And they're going to find out that it is something to do with bleeding coagulopathies. And this is usually how they find them. How do we take care of this kid with a nosebleed? Well, we don't want to head back. We don't want them to swallow it because they'll vomit blood and then make the nosebleed more. Lean them forward and try to get them calm. This is the child that's going to go right into their parents' lap, because the parents is where they're comfortable, and have them hold it and lean them forward for like 10 minutes and hold it until the bleeding stops. HIV/AIDS is usually from mother to child. As adolescents, though, we need to teach, abstinence, but we know that, adolescents are adolescences, and at least to teach them safe sex routine. But if it's a mother to child, hopefully we have been given this mother, some highly active antiretroviral therapy. So antiviral therapy during the last part of their pregnancies. And then immediately after birth, we are continuing those. Our goal with HIV and a newborn is to improve their immune function, because newborns born from an HIV mother do not necessarily need to have HIV. You can convert that so they have no HIV. It doesn't mean every child born to a mother with HIV, all the babies will be HIV positive. They're not. I've seen twins, one with and one without. So it's, we can save some of them from a lifelong course of HIV medicines. Prognosis is good with this early recognition and understanding. If the HIV mother has gone through prenatal care, is the best, and has received antivirals, and then to continue it after birth. And again, goal of the newborn is to improve their immune function, and they can fight against this HIV. The most common opportunistic infection is PCP pneumonia, pneumocystic cardiac pneumonia, and it's all about respiratory, all about breathing. And we usually see that between 3 to 6 months of age that we'll see these children. So what is our goal in HIV? It's that education, of course, prevention. If a child has it, it's monitoring their pain and trying to medicate them as needed. And then these newborns are HIV positive, and we need to keep that confidential, especially with these open nurseries, so that not everybody knows, oh, that baby has HIV. And of course, you know how people connect to that. Like, I don't want to go over and touch that baby because they're dirty. They've got that disease. So technology and hematological and immune disorders, what do we do for it? Well, any sort of hematological, we're going to probably consider with what I've talked about is blood transfusions. Be aware that there are blood transfusions reaction. It could be flushing, rashing, could be anaphylaxis, or it could be no fever and half an hour later having a fever. And what's the first thing we do with any suspected blood transfusion reaction? Turn it off. Stop it immediately. and then of course we'll take the bag and send it down to the blood bank. Now, as I mentioned before, apheresis, we would do that to take the iron off the blood. We can do that and we can separate all sorts of components off of the blood. We can even save platelets out of that, from the families to give to that child, maybe with ITP who needs platelets. So when both parents have sickle cell trait, what's the chance that each of their child will have sickle cell anemia? Which one?
25.
Yes, it is 25%. Good job. So neoplastic disorders is the leading cause of death from disease in the children past infancy. And half of those are blood and blood forming organs. And these are leukemias and lymphomas. So leukemias has to do with a malignant disease of the bone marrow and lymphatic system. It is the most common cause of childhood cancer. And it is more in boys, and it's usually the peak onset ages 2 to 5 years old. So you can imagine you have a 2-year-old child sees the doctor, they do a CBC, they see the lab results, and now your child is leukemia. It is quite devastating and quite overwhelming. These parents need support. Survivability is great. The survivability chances are very high to go, but it's going through a big treatment, and it does take a lot out of a whole family group. So leukemia, what is that definition? It is the unrestricted proliferation of immature white blood cells in the blood forming tissues. That means white blood cells are formed, but they don't work. You will see white cell counts of something like 0.1, and your normal count should be 5 to 10, somewhere. It's not going to be 0.1. So there is no immune system here. So how do we evaluate leukemia? Well, it's history. What's going on in the history? You're going to see bone pain. You're going to see general tired fatigue going on, and you're going to see bruising going on. These children have really low white counts, and usually you'll have really low blood counts. Hemoglobin hematocrits are also low, so that's why they're tired. And then platelets are low. So now you've got the bleeding in there too. So we did your CBC, we did a smear, and we see these immature white blood cells, the leukocytes. They're all looking immature. So now we know. Next, we're going to do a lumbar puncture because we want to make sure, is it not in the central nervous system and only in the blood? That's one thing we have to do because we have to put chemo in the central nervous system if it's involved. And then we're going to do a bone marrow biopsy or aspiration because this is where the blood's being formed. We want to see what it looks like in the bone marrow. Now, once we determine this is leukemia, there are 4 stages of chemotherapy. And the first one is called induction therapy. And this lasts between 4 to 6 weeks. And the goal is to achieve remission. So hopefully at this point, we've eradicated all of these cells in the body. And then we're going to put it into the central nervous system to be sure, and then put them on the therapy to make sure if there's 1 or 2 little cells left, we get rid of them and then go to a maintenance on them. So induction, those 4 to 6 weeks, this child is hit with chemo more than one type, trying to get rid of the cancer out of there because we want remission by the time we're done with 6 weeks. Now, many times we have to go to a hemopoetic stem cell transplantation, and we can have donors, relatives, it doesn't have to be your blood type. It can be many different types of blood that is used here to to know the two names, autologous, the patient's blood. Okay, that's the best if we have it. We do have umbilical cord blood now for infants, because remember, 2 to 5 years old, this is when it happens. So autologous would be a great one to use. But if not, we have the allogenic, and we know siblings is probably the best blood for the stem cell transplant next to the patient's own blood. So again, leukemia, it's going to be intense. These children are not going to feel too well. They are going to be prodded and poked in many different places. They will be placed a port so that we're not going to have to stick them with peripheral IVs all the time during this. The children and the parents are taught how to put that nice numbing cream on, that EMLA, before they come in for any procedure, so it's nice and numb. So teaching these parents those things and the older children, any pain, of course, take care of it and then prevent these complications. As we are killing the cells, these white cells that are not good, we're also killing other cells. So these children have no white count. These children are totally immunosuppressed, myelosuppressed. So infection is a big deal. And because platelets go away too, working out for bleeding and hemorrhage and anemia. So trying to prevent these by giving blood transfusions, by, good practices, hand washing, keeping people who are sick away from them, so important, because that can hurt a child by getting an infection during this process. And we know nurses have to take really good care with this chemotherapeutic agents. In fact, if you wanted to be a pediatric oncology nurse and you get experience, there are many hospitals who pay big things if you come to work for them. It could be a $20,000 bonus to sign on. That's how much they need pediatric oncology nurses. So prognosis of leukemia depends on what was their normal white count. What was it when you first came in? Was it 0.01 or was it 0.1? There is a difference there. How old was the child? Are you a boy or a girl? Is it the leukocyte or is it the monocyte? Now, ALL has higher chances of recovery than AML. AML is harder to cure. So a leukocytic leukemia is actually, if you want to say, the better type to get, it is. And then it doesn't, when we're giving blood to these children, they're constantly requiring, blood, platelets, and they have to get their type of blood. If they have a weird, very rare type of blood, they're not going to get their blood on time. So it does make a difference, their karyotype analysis. And now children with cancer. Cancer in children, we do a combination therapies. We do chemotherapy, radiotherapy, and surgery as needed, combinations of drugs. And as I said, we're going to have that venous access device like ports, and we're going to have nurses trained to give this. So usually, if we can detect early what's going on, your outcomes are so much better. So what are signs and symptoms? Well, I've already told you I saw in this young girl pain, we saw ecchymosis, and we saw general fatigue. Those are key, like golden things you see. But then we see petechial, we'll see weight loss, anemia, firm enlarged lymph nodes is something we see, and we know we shouldn't. And then sometimes visual changes. So as we're giving chemo, we know that chemo also destroys good cells. And we know that one of the things that we're concerned about, especially with a child with leukemia, with no white cells, that they're open for infection. So we need to monitor them for septic shock, which is infection. So we'll be monitoring their neutrophil count. Neutrophil counts are white blood cells that fight infection. So what are the numbers? What do we need to know? Well, if your number of neutrophils is less than 1,000, 500, and it should be like about 1,500 is the normal number in children. If it's lower than 500, you are really susceptible for infection. So we need to make sure as nurses, we prevent infection. The big thing is hand washing. It's hand washing. And of course, if you're sick, you shouldn't be taking care of this child, or at least wearing a mask on them. So we'll be with these children. They are constantly, again, if you have a fever of 100.5, tell your doctor, go to the emergency room, and we'll be starting the port, and we will start an IV, and we'll be giving IV antibiotics because the child has absolutely no immune system. And again, watching for infection. Another big deal is hemorrhage. I told you their platelet counts are down to nothing. No platelets, they need to be on blood precautions. So they'll be getting transfusions. These children at home during their process of going through leukemic treatment, make sure that they're not out riding their bikes. Anything that's going to cause harm, which could cause them to bleed, internally. And of course, protecting them from infections. And then we know it's killing red blood cells, and hemoglobins and hematocrits are low on these children. So they're going to be tired. So try to limit their activity and try to keep them quiet so that they can conserve their oxygen, what they have. Nausea and vomiting, we should be administering antiemetics before, 30 minutes before, and then 24 hours after, every 4 to 6 hours, whatever it's ordered for. They're using synthetic cannabinoids in these children, and it's actually done a great job. Some states are more easy to get than others, but it does help. They're not going to be eating. They don't feel well. They're tired. They get these ulcerations in their mouth. They're not going to want to eat. And we know nutrition is so important. So monitor what they're taking in. What is their nutrition? Looking at their height, their weight. And then we're going to be watching the protein in their body. Because not enough protein, fluids are going to go interstitial, and this child's going to swell up. So we'll be watching the prealbumin, the transferrin, and the albumin. And if we can get a good diet in them, high protein, high calorie, high fat, we want to give them everything we can to give them the nutrition that they do need. As I said, their mouths can become eroded, but it's the whole GI tract. From mouth to anus can become all eroded and painful. And of course, this doesn't help with trying to feed these children. The food, nothing spicy, should be bland, soft. They can use mouthwashes, but they don't want you to do those numbing ones because they can choke on them. That's the reason why. And if it's something rectally, a sitz bath is great. One of the things is they can have neurological problems. Remember, their blood is thin and they can bleed. You don't want them bearing down hard and pop a vessel in the brain and cause now a stroke. So stool softeners, monitoring stool habits. If they're in bed because they're so tired and weak, remember, children can get decubitus and foot drop just like adults. So making sure that we're monitoring them. They do get peripheral neuropathies from these chemotherapy, so they can get this numbness in their legs. So if they're having troubles walking, this could be due to those chemos. And of course, give them something for pain. They even get jaw pain. And if you've ever had jaw pain, you try to eat, you don't feel like it. I get it with my RA. My jaw hurts, and it's like you don't want to chew. It's like, give me something to drink. I'm not going to chew because it hurts. It's uncomfortable. They also can get hemorrhagic cystitis. So fluids, again, I told you, fluids are difficult to get in, but we really need to try to get it into them. So it keeps flushing all of this chemo out of the body. They say that they should have 1.5 times recommended You're lucky if we can get one time in these. And to make sure that they're going to bathroom, make sure that they're frequent voiding. If it's because they're tired, put a commode next to them so they don't have to get up and run to the bathroom, because that could be what it is. And of course, always watch the color of the urine. We know that hair can be lost, and many families will go ahead and cut their hair off, especially dads. I've seen that. You'll see the bed just full of hair in the morning. Many of them will just go ahead and shave them or cut their hair really short before, but if they don't, that's what you see. I tell you, I used to bring in ribbons, and I used to say, okay, what color are we going to be today? Or you want rainbow color today? And I would put one in my hair and they'd put in their hair, and it just made them feel sort of special. They had special ribbons for the day. They're also given steroids, and Cushing disease or swelling up from steroids is very common in this treatment. So be careful with the salt intake of these children. And if the child's older and aware of their body image, put them in looser clothes. If there's gowns in the hospital for children, give them the next size up so they don't feel like they're, so showing all of their bigness. Again, procedures, always explain. Most of these things are done under sedation, whether it's just the midazolam, which is Versed, or under propofol, but they will sedate them. Bone marrows hurt, and they are going to be knocked out a little bit for that so that they can get through it. Again, if you're doing a procedure and it's just a little sedation, be honest with the child. Say, we will do everything at all possible to stop the pain, but you might feel a little. Be honest about it so that they're aware. They will be getting a port. They do that in the OR. They don't feel it. Again, that topical anesthetics, teach them about that, putting it on there before we go in. And they do, as they're doing bone marrows, will be inserting lidocaine on the top topically, and as they go down, they squirt a little bit more in to try to decrease pain. Always be mindful of pain in these children, and it's just not the morphine, it's just not narcotics. Remember, a little bit of Toradol or ibuprofen with morphine works really well, and to make sure the pain team comes in so you get what you need. We can titrate up, we can do as best as we can for these kids to keep them comfortable. So lymphomas, there are two types, and it is Hodgkin's and non-Hodgkin's lymphoma. Hodgkin's is the lymph nodes, and you see metastasis to the spleen, liver, bone marrow, lungs, and some other tissues. What do you see with Hodgkin's lymphoma? If you see that picture, it's a big, big lymph node. The thing about it, it's painless. They don't feel it, but you see these big lymph nodes. With that, because of the swelling going on, you might see a cough. You're going to see sometimes the tummy hurts, they're not eating well, fever and night sweats. So how do we diagnose Hodgkin's lymphoma? Well, of course, it's the history and looking at these painless cervical nodes here and doing a bunch of lab works. The CBC, liver function, we're looking at CRP and SED rate to look at inflammatory factors, and we'll be doing just a simple urine and x-rays to look at where are these lymph nodes, what do they look like. Now, the definitive way to diagnose Hodgkin's disease is to do a lymph node biopsy. And what you see is Sternberg reed cells. So if you see Sternberg reed cells in the lymph biopsy, it is Hodgkin's. Treatment, radiation, chemo, or both, great survival rate. Great survival rate with Hodgkin's. And usually those big nodes bring the family into the doctor soon, so they can usually get treatment really, really well. Again, always prepare the child. We know with any chemoradiation, doing all the things we can to prevent these side effects. And the one thing about chemoradiation, many of these children will not able to have children in their future. They become infertile. Non-Hodgkin's lymphoma is more diffuse spread. You don't see like the big lymph nodes. You'll just see things all, as you can see, the different sort of pictures all over the place. So what do you see is you're going to, most of the time you'll see bone marrows where it metastasized, and central nervous system, you'll see it. And sometimes it looks like a leukemia. But what they'll do is they'll go in and do a biopsy, and they will confirm it that way. And of course, they'll do the CT to see where is it. They're going to see these diffuse little areas. Again, radiation and chemo, and usually they'll do the same outcome as Hodgkin's lymphoma. Again, induction, goals to eradicate it, consolidation, maintenance, and then they will go into the spinal fluid and give some radiation chemo there to help it. Brain tumors. Now, brain tumors is the most common solid tumor in a child. Symptoms that you would see with a brain tumor is maybe visual problems, maybe headaches, vomiting. But you're going to see these symptoms get worse. They're going to have progressing symptoms. It's not going to be vomiting with meals. It'd be vomiting whenever. Headaches, it won't be minor anymore. It's going to be a headache all day. And this is what you would see with them, whether it's cancerous or not. We treat it with chemo, we treat it with radiation, and then we go in there and get the tumor out with surgery. So sometimes because of where it's at, you might have some neurological dysfunction. Sometimes you don't, but it just depends on where it's at and how much we can shrink it before we do surgery. Now, post-operatively, these children require very careful post-op care. These children, some can lay on the surgical site, some can't. Some can only be up 45 degrees. You can't put them straight up. So knowing positioning of the child, that's number one. Another thing is intake and output. You can't overhydrate these children because it's going to cause swelling in the head. Where does all of that fluid go? It can go into the head and cause problems there. Keeping them well, comfort, and keeping that family, understanding of what the child's going to look like. The child's not going to come out looking with a tube hanging out and the dress and the surgical site. It's going to be a big bandage on the head, and it can be really daunting. Then they see this tube hanging out there, and they just, what's happening. So preparing them. And then our goal with any sort of brain tumor removal, even if there's going to be some deficit, is to promote the best that this child can be, so optimum functioning. Now, a neuroblastoma, you think it's neuro, right? Nerve, but it starts in the abdomen. It is a tumor. Most of the time, it will come off of the kidney. It'll get big and it will cross the midline and take up the whole abdomen. But that's usually what's not caught first. It's usually the head because it metastasized to the head. So it's already metastasized by the time they figure out the child has a neuroblastoma. And they usually will see things like the eyes being popped out, bruising around them, swelling, or you start seeing them neurological dysfunction like pupils or not moving a certain side or an arm or a leg. And this is what you see. And by the time you're seeing that, it's in the head. That means the one in the abdomen's gotten really huge. I mean, if the belly looked like this little infant down here, you'd say, okay, I got it. But usually it doesn't get to that point before they've already been metastasized and they can't even see the belly yet. So what do we do for these? Well, we are going to do surgery to remove the tumors as much as we can. Thank goodness, this already metastasized, so it's not a great outcome. But it's a very small amount of children that get neuroblastoma. So thank goodness. And now we're going to talk about a bone tumor. It's called an osteosarcoma, and it is in the femur bone, usually adolescents and a lot of times boys. Usually these boys will start complaining of limping, pain in their knee, their leg, their hip, which gets worse, and Tylenol and Motrin's not really helping. And by the time it gets so painful, they go to the doctor, they do an x-ray, and they'll see like this little white fuzz on the shaft of the femur bone. Also, if they've waited long enough, you're going to see them already anemic. They're losing weight, and what we need to do is that x-ray, CT, let's see exactly what's going on with the MRI, and if we can, we'll do a biopsy just to confirm the diagnosis. So what do we do for an osteosarcoma? Well, we have to take the bone out. There's no taking a piece out. That whole femur has to come out. So if you can imagine, from the hip to the knee is gone. So if we didn't take the lower leg and tried to put it where the upper leg was, there'd be nothing to connect the prosthesis to. So our goal today is to salvage that limb, to save the limb. And if you see the picture, they put it on so they can put a prosthesis on it, and so that it can now be part of the leg. Yes, it looks strange, but isn't it better to have a piece of a leg to be able to put prosthesis to be able to walk around instead of being in a wheelchair? They really do not like to take off the whole leg, although sometimes they have to. So surgery is chemo, surgery, and then it's going to be physical therapy to teach how to walk with a prosthesis. But once that bone's out, the cancer's gone. Wilms tumor is a tumor off the kidney. It is in boys ages 3 to 5, many African American, and you will feel a large mass in the abdomen somewhere. I've seen one in my lifetime. It was right after the Haitian earthquake. This religious people sent this little boy over with all the papers in French, picked him up at the airport, and brought him directly over to the ER, and I was the triage nurse. And I'm like, why is he here? And they go, we don't know. We were just told to pick him up. Here's the papers and bring him here. I said, okay, well, let me just do an assessment. So I couldn't speak to him. He was 3, so even that was hard to do. So I did vital signs, did a neuro check, listened to the lungs, I listened to the abdomen, and when I got to the left lower quadrant, I felt a softball-sized mass in the abdomen. And I don't know why I knew, because I had never seen one before. I knew it was a Wilms tumor. And I don't even remember where I read it from. This is before I was teaching. I don't remember. I knew that we shouldn't be touching that. So immediately I put a sign, do not touch abdomen. And I let the nurses know what my feeling was. Why don't we touch that abdomen? Well, this mass is very fragile, and pieces can break off and go into the peritoneal cavity, and it could cause metastasis. So the biggest do not is do not palpate abdomen of a child with a Wilms tumor. It is a malignancy, and they'll do chemo, they'll do surgery, some do radiation, but usually it's just chemo and surgery, and they do really well. Now, one of the things with this after surgery is now we've taken this big tumor out of the abdomen, off the kidney. So we have to watch the intestines, which is monitoring bowel function, and we will be looking for infection, and we'll be watching urinary output because it was on the kidney. So that's post-op. They do well. That little boy went back to Haiti and did well. Rhabdomyosarcoma is some soft tissue. It's just out of the eye, could be in the ear, sometimes the nose, and sometimes all you see is an earache or runny nose, and the physician finds it, and they have to surgically remove it. That's a rhabdo. Retinoblastoma is a tumor on the retina. And one of the things you see with this is this white glow. It almost looks like a flash went off and you don't see that one eye. This is like, we call it a cat's eye reflex. It's if you ever got in your backyard when it's dark at night, shine a light. If there's an animal there, you see the white shiny eyes, especially cats. Well, that's exactly what it looks like. I've seen one and the kid was 9 months old. And what the treatment is they remove the eye. That's what they have to do. They do radiation, chemo, they take the eye out, and these children get false eyes that they can put down in the end. But this is devastating to see on a young child at 8, 9 months old. You know, some of them are older, but most of them are younger when you see these things. Retinoblastoma.
The retinoblastoma is seen without shining any light in their eye.
Yeah, you see it. It's just white. You see it. I mean, if you put a flashlight, you would see it more pronounced, but no, it'd be just there. You can see it. It's like there's something wrong here. Germ cell tumors are testicular things that can go on with males. This is why males should do testicular examinations, just like we do breast examinations monthly, because you can get tumors in the testicle sac. Now, I had an 18-year-old boy come in with complaining of testicular pain. And he said it happened about a month ago. It started to hurt. So I was in the room with another nurse and she said, okay, pull down your pants. And she needed to check it to send him in. It was already the size of a softball. So they did x-rays and he already metastasized. It was already in his lungs, his bones. It was everywhere. And that poor 18-year-old boy who didn't come in early died within 3 months. You know, we've seen outcomes of testicular cancer where they have been cured. Even some famous people have been quickly, but it's early recognition. Liver tumors, you know, livers have multiple lobes. We can take out the tumor and we could be fine. So if it's a huge tumor, of course, the whole liver can come out, but you transplant, but usually just the section is taken out on these. So cancer survival is better than it's ever been, and it's getting better every year. It's up to about 80%. They're doing all different chemos, different modalities are being done, and so many good things are happening. So, you know, our goal today is just cancer-free for these kids, and they go through a lot to get there. If you've ever been involved in a child going through cancer treatment, it's a lot on the family and a lot on the child. Any questions? There's a lot of not nice things on this slide this week. So who wants to win a Cahoots? Bella does. Who else? Michelle does. Who else? Oh, Mario. Who else? Everybody? You all are so wide awake and alert. You look so tired. We got 44 today. Not too bad, okay?
Professor, should we look over this Cahoots for the exam, or this is for the next
This is for this exam coming up. This is on this exam. I would suggest anybody studying for the test, you know, you have every week gone through your interactive PowerPoints, you know, you've read your book. As a study guide, I would do the PowerPoint. I've spent a lot of time making that PowerPoint for your review. I'm the one who did it. I made it for you. I know that everything's there that you need. I also know that that review, that PowerPoint is good for your HESI too. I know the information is there that you'll need by the topics they say that are there. And it's also great for your NCLEX when you come to that point. So these review PowerPoints are awesome. So study the review PowerPoint and study your Kahoots, and you've got everything you need for the exam. All right, let's get going. Which statement best describes a neuroblastoma? Remember I told you this is a really sneaky one. It starts with that tumor in the abdomen, and by the time you know that it's there, it's already in the brain. And it's usually those symptoms that tells you. So metastases are already there. Yep, very good. What is sickle cell disease? So sickle cell disease is a genetic disorder that affects the production, okay? The production of hemoglobin, it is produced in a sickle shape. It doesn't restrict the oxygen. There's a cell, oxygen go there, it has nothing to do with the restriction. The sickle cell shape is what restricts the oxygen, okay? I know that's a tricky question, but make you think. What is priority treatment for a newborn of an HIV positive mother? What do you want to do for that infant? Priority. So we want to make sure we boost that immune system the best we can. Antibiotics, what are they going to do? It's a virus. Isn't that a virus? HIV virus? So antibiotics, nothing. We want antivirals, improve that immune system. What are symptoms of sickle cell anemia? And which is the best one? So hand, foot swelling, pain, vision, delayed growth. Because remember, no oxygen, not good nutrition, you're going to see that growth delay. Jen's up top. Sickle cell anemia affects which cells? Absolutely red blood cells. I wanted to be sure you knew that it's red blood cells. I always have one or two students that don't know. So red blood cells. What kind of hematocrit would someone with sickle cell have and why? Remember that chart? You know, some lose cells quickly and not produce, or it's a loss. Which one is this one? And it's because they die faster. It's low. Remember, hemoglobin hematocrits on sickle cell children, you'll always see low. As I said, I saw many. It's 5 and 15, 7 and 21 would be the highest I would see on a child, adolescents with sickle cell. That's what I see all the time. What is the treatment for sickle cell anemia? Remember, number one's IV fluids. Excellent. IV fluids, it's going to be antibiotics, bone, blood transfusions, and bone marrow if it gets to that. And Jen's still up top. Aplastic anemia includes a depression of which blood cells? Remember A. A is absent, like atresia, absent. A. Aplastic. A, absent, red blood cells, white blood cells, platelets, all of them. Mamika's on fire. Most common type of anemia is? Iron deficient anemia, most common. What causes pernicious anemia? Pernicious anemia is all about the intrinsic factor. And that's a B12 deficiency. Very good. And Ari's on fire. Which symptom is the single most common symptom of anemia? I mean, there's multiple things, but it's usually what brings them, the child, into the doctor. And that's that overwhelming fatigue and being tired. Kids not themselves, something's wrong. When teaching parents about beta thalassemia, the nurse informs that the child is at risk for what? Thalassemia, Cooley's anemia. Or these are those rectangle-shaped Mediterranean descent people. They explode and explode. And what happens? No red blood cells, you're hypoxic, and the iron is in the blood, okay? Chronic hypoxia and iron overload. The nurse is caring for a child who's just died, and the parents asked to be left alone to rock their child. The nurse should do what? You know, it's probably one of the hardest things in nursing to have one of your patients, especially a child, die, an infant especially. But you need to give them their time. You need to give them what they need. Do they need clergy? Do they need the social worker or nobody? But give them the time that they do need. What is hemophilia? So hemophilia is number one, a missing factor of some sort, but you'll see the PTT prolonged just like heparin, but the PT and platelets are absolutely fine. What is thrombocytopenia purpura? Idiopathic thrombocytopenia purpura. ITP, what is a P about? Remember, P means? It's all about the platelets. Remember, whenever you see anything that has a low platelets, nursing priority is bleeding precautions. Amika's up top. Thrombocytopenia can cause the following symptoms. Lack of platelets can cause what? And that is that petechial hemorrhage. You'll see that little petechial rash, little purple looking thing. Of course, bruising, and that sometimes it's the nosebleed that got him in there. A multi-select. Child with hemophilia has fallen and the knee is swollen and painful. Treatment would include what? You have a child with hemophilia, they bleed, they have fallen, and that knee is swollen. Means it's bleeding like crazy in that joint, and it hurts. How are you going to take care of it? How are you going to stop that bleeding? You're going to elevate it and put cold packs on it. You're going to rest, ice, contain, and elevate. Absolutely. Just like a sprained ankle. What is a priority nursing action for a suspected blood transfusion reaction? Number one, stop it. Very good. And it doesn't matter if it's an antibiotic given in a reaction, anything that's creating a reaction given IV, stop it immediately. A child is admitting with neutropenia. Which nursing action takes priority? What is neutropenia? Remember, neutropenia is the white count is low. There's no immune system. You as a nurse, strict hand washing. Contact means they have something you can catch, so it's not contact. It is strict hand washing, and wear a mask if you're in doubt. Which symptoms would a healthcare professional expect to see in a child with leukemia? So leukemia has a low white count, low hemoglobin, hematocrit, low platelets. They're going to be bruising, they're going to be tired, they're going to be in pain, bruising, fatigue, and bone pain. Very classic leukemic, what brings them in for treatment. Your child with ALL, leukemia, has recent lab results with platelet counts of 10,000. Your nursing action is what? Platelet counts of 10,000. Always think bleeding precautions. What does that mean? No IM injections, watching them for bleeding, soft toothbrushes, no razors, all of those things, bleeding precautions. Platelets low, beware. Child with Wilms tumor, what action by the nursing student causes faculty member to intervene? Wilms tumor, 3 to 5-year-old boys, African American. Huge tumor in the abdomen. And if you touch it again, we'll have problems. Just leave that belly alone. Let's keep that child safe as we can, for sure. Cancer of the body's blood-forming tissues, including bone marrow, is called what? And that is leukemia. Wendy's on fire. All of the following are true concerning a neuroblastoma, except. What do you know about the, you say neuroblastoma, you think of the head. Remember, it starts in the abdomen, and by the time the symptoms of the head come out, that's already the metastasis to it. It's not common. It is not common, thank God. Remember, only 6% of all cancers are a neuroblastoma, which is really not common. Most common clinical manifestation of a retinoblastoma. With or without light. And that's that cat's eye reflex, that white shiny that you'll see. True or false? Immunizations causes autism. Absolutely not. Immunizations are prevent diseases. That's all they do. A child is complaining about these skin markings for radiation. Should be told what? You know, a lot of times they'll put these little purple things so that the radiation can get where they need to go. It could be on their face if it's something in their head. And it bothers them. But you're going to leave it there because this is where the radiation needs to go. So radiation markings have to be there. They spend a lot of times putting that color there so they know where to give the next treatment. So do not remove them. A multi-select. Nursing care of a patient with immune thrombocytopenia purpura. Nursing care. Remember, they're susceptible to bleed, so no IM injections, no, we're going to watch their CBC and steroids, PRN, the corticosteroids. Sickle cell needs IV fluids to dilate the vessels, but ITP has nothing to do with the vessels. It's bleeding like little rashes and ecchymotic area. So IV fluids, no. The rest, yes. When distraction is used in children, it helps to do what? They're working in a children's hospital. It's great. They have video games, they have music, they have cartoons, all sorts of things to help children. And literally it keeps their mind off of what's going on. I think it's great. I mean, I used to always carry a pocket full of stickers around with me. They love stickers. What assessment question needs to be asked to a child with possible rheumatic fever? Question from last week. Rheumatic fever is caused by what?
Correct.
Yes, ma'am. Have you had a sore throat or a fever in the last 2 months? You don't know where it came from. Remember, rheumatic fever is due to an under or not treated strep infection. How do we treat it? We're going to give them a long-term course of antibiotics and all of the symptoms will go away. Signs and symptoms of asthma. Another one from last week. What do you see? And you'll see everything: coughing, shortness of breath, chest tightness. You're going to hear wheezing, retractions, a prolonged external expiratory mark. They're going to be breathing, trying to get the air out because it's stuck in there because of all the swelling going on. A multi-select. Absolute contraindication for nasotracheal suction include which of the following? And I've told you not to look in the mouth at all. So suctioning would be absolutely you wouldn't do. And it has to do with, you already have swelling with epiglottitis. You already have swelling with group. So you are not going to do it. Doesn't matter with asthma, irritable airway, because that could be due to secretions, but croup and epiglottitis is a swelling, an inflammation, and you don't want to increase that inflammation any more than it already is. Iron dextran is given via which route? We use this for iron deficient anemia. And it's IM Z-Track. This is iron dextran, and Z-Track because it burns and because it is brown and will discolor the skin. And V is on fire. Which cancer may present with painless, firm, enlarged cervical nodes? Painless. Remember that boy in the picture, big node? And that's Hodgkin's lymphoma. Very good. Good job. Thalassemia major is treated primarily with what? Thalassemia major, Cooley's anemia. How do we treat it? Mediterranean people. And this is blood transfusions because their cells burst. And when they burst, all the iron goes into the vasculature. So now you're hypoxic and you have iron. So you have to take care of the iron, and you need to do something for the hypoxemia, which is give some blood with good red blood cells, which will have oxygen for that child. True or false? A yeast infection is an opportunistic infection of HIV. It absolutely is, and it's important to treat it because yeast, you think is a little thing like in the mouth, but it can get big chunks, and on younger children, it can really obstruct the airway. So yes, we're going to give that monostat, that nystatin for the mouth, or the monostat for a yeast infection for a woman. A multi-select. Treatment of osteosarcoma includes what? Well, osteosarcoma is the long bone of the leg, the femur, mostly in boys, adolescents. And we're going to treat that with chemo, radiation. Hopefully, we can salvage the limb, but a lot of times it ends up with an amputation. So our goal is salvage, but many times we have to amputate. And Mary's on fire. Who are the best donors for a bone marrow transplantation? The siblings are good, okay? But if you had yourself first, many don't. But siblings are a great donor for transplantation. What is the most common opportunistic infection for children with HIV?
I have a question about that last one, because self was an option and then sibling was an option. So why wasn't it self?
They're both good, but most of the time you don't have your own. If you're looking at bone marrow, you don't usually have your own. You might have stem cells from you're an infant, but bone marrow you don't have saved.
Okay.
That's why it's siblings. Does that make sense?
Yeah.
And pneumocystic is the most common HIV. And if you look at pneumocystic, it's all about respiratory and worrying about it. Remember, these are young children, usually 3 to 6 months, that get the pneumocystic. It's very scary. What would you consider to be neutropenia or a low neutrophil count in children? And the best choice is less than 500. I mean, 500 to 1,000 is getting low, but less than 500 is really low. And this is the one that we have to be careful of infection, and hand washing and wearing a mask if we need to will be done. A primary characteristic of a brain tumor is so it is headaches, it is vomiting, but not related and not occasional. It's those symptoms of those headache and vomiting become worse and worse and worse. And last question. A child is receiving the induction of chemotherapy. What does that mean? So induction, we know, is the first 4 to 6 weeks. We hit them with 1, 2, or 6 chemos, whatever it takes, because our goal is remission, which means we're going to have all but very few cells left. And that is our goal. Good job. Let's see how we did. Number 3, Jen. Good job, Jen. Number 2, Ari, you did it again. Number 1, Wendy. And number 4, V and Lamika. Good job, guys. What I want you to do is sign your attendance attestations. Make sure you get them done. You know, I hit you every week with it, but I'm telling you, they're so important. I actually got a message from the dean today, global to all of us online, that there are students that, just doing the attendance attestations, they're not doing them. And what's happening is they're getting taken off the course. They're being removed because that looks like they're not working in the Canvas. Because remember, you need 2 points of contact every single week. And I made that so clear in the beginning. And I never want any of you removed. That's why you'll see me put zeros there or send you a message, hey, sign your attestations, because I would hate that to happen when you're working so hard, to keep up. So anyway, I'll see y'all Thursday if you come. If not, you'll get my recording. Have a great
Professor,
night.